So I represent Harlem United Community Aid Center. We were founded in 1988. And like many organizations at that time, we were a boutique organization, a niche organization, specifically founded to serve people living with HIV who were homeless, substance users who were not necessarily injection drug users, who were a known population at that time to be heavily impacted by HIV, but also those suffering with very severe and persistent mental illnesses who oftentimes were considered hard to reach, hard to engage, and sometimes kicked out of provider offices for their own behavior. We're the agency of last resort today for medically underserved communities of color in Harlem, meaning that if you provider is having a hard time with a patient, they will often refer them to us to be part of our adult day health center. So they just call us up when they're ready to see the patient, and we make sure that the patient gets to where they need to go. We don't try to be all things to all people. We are a large organization. We're about $37 million big. That's comprised of supportive housing units, over 500 units of supportive housing, an HIV prevention division, as well as our healthcare services, which include dental services, primary care, and behavioral health. So you say, wow, Cadillac program, but everybody in Harlem comes there. They don't. It's really for the people who are on the periphery of our mainstream society. So it's the hepatitis C positive people, HIV positive, people who've survived violence and trauma, who we often don't talk about actually as a risk group, but the result of the violence and trauma that they've suffered does lead to mental illness. It has put them in the path of HIV and hepatitis C, so we do have programs specifically for them, and of course our drug users, mentally ill, and homeless people. We've taken all of our divisions and created an interdisciplinary comprehensive approach, something that you hear about nowadays when we hear a lot about medical homes. Medical homes in many places have existed, continue to exist for people who are HIV positive. But often now we find syringe exchange programs work. You now have treatment options that in some communities can really reduce viral load so that you have less transmission of HIV. What you find then is you have the same mentally ill, chemically addicted people, chronically homeless, who just don't have HIV, but have hepatitis C and all of the other chronic conditions that need to be treated and need to be treated in an interdisciplinary model. So what we did this year is we restructured our organization from those 3 divisions I told you about into 2, and I'm responsible for the division on the left, which includes our patient-centered primary care and dental services. And so I'm going to talk to you about 4 initiatives today, but I just want to let you know that I do also have handouts from our Black Men's Initiative program. That's our Young Men of Color Who Have Sex with Men initiative. It's more than just HIV prevention, and it's more than just access to care. As a population that is probably the most hardest hit today with HIV, we have to help them understand the HIV in the context of a lifelong plan of prevention and care. It's going to be with them for a very long time. And so we do have programs for them that are a bit outside the medical home model, but do also include that. So I'm not talking about that today, but I did want to let you know I have literature for that. So what am I working with in Harlem? So this is just some data. You've heard about the disparities. You've seen the national numbers. Locally in Harlem, we have rates that are 3 times in Central Harlem, 3 times the diagnosis rate for the average of New York City. We have twice the prevalence, and we have 50% higher death rates in Harlem. Second and third highest rates of HIV diagnosis and prevalence in East and Central Harlem. Number 1 is Chelsea, and that's kind of what we consider the epicenter of HIV in New York City, and it's the white gay community downtown. While they have almost a 5% diagnosis rate, their death rate is less than the city. So that begins to kind of give you a sense of what's really happening for people. Here you have less HIV prevalence than Chelsea, but far higher death rate. STIs, very much similar story. So you see New York City rates are high enough, and you saw that also in the slides that were presented to you earlier. But look at Central Harlem. For the men in Central Harlem, rank first for chlamydia and gonorrhea diagnoses, and this is ages 15 to 34. Women in the top 10, in the top 5 for Central Harlem, but within the top 10 in East Harlem. I also want to point out, I didn't put it on this slide, but I would like to call everybody's attention to the looming hepatitis C crisis that we have, that we don't necessarily have an infrastructure or docs to take care of, but I did have some hepatitis numbers to share with you. In East Harlem, 451 cases diagnosed in 2009 per 100,000 residents. So 451, pretty much right up there with just the New York City average for STIs. And when you consider in the prior slide, 137 per 100,000 HIV diagnoses, I think you begin to get a sense of what we're working with in HIV, STIs, but also the looming crisis with hepatitis, which for many of our clients are duly diagnosed with HIV. So our challenge and our response, we have, as an organization, we are rich in mission and vision. People come to work every day with ideas and energy, and they work their butts off. What we just don't often have enough of is money to do the work. So what we're challenged in doing, as many I'm sure of your CBOs are, is how do you marry the money and the funding streams that you have to create these comprehensive programs? So what I'm going to talk to you today about are 4 initiatives that we have. One is our universal testing program through blocks 1 and 2, our integrated HIV STI screening, building community capacity by training local ministers, and building collaborations with local government, and that's the I Talk About HIV videos in addition to some other things. So our testing projects, what we did is we put all of our testing programs into one pot, and we said, what's the best way to make this work? So we have our zone-based testing, we have risk-based testing. Risk-based, we go after drug users, men who have sex with men, high-risk women, and immigrant populations, mostly through venue-based testing. Where do they go for services? Where do they go to church? Where do they shop? And we try to catch them out there and do HIV testing. We also run an effective social networks program right now for young men of color who have sex with men. But Blocks is an interesting project because we had a hard time getting our funders to believe that this was worthwhile. So the CDC guidance that came out in 2006 recommended routine testing for people in clinic settings. But as a CBO, we were still required to target people based on risk. It didn't quite make sense to us when we have almost a 3% positivity rate in our neighborhoods. So what we decided to do was solicit some funds from MAC AIDS Fund and from Gilead Sciences. We're not opposed to taking money from pharma if you don't make us sell your meds. We geocode our clients. So what we did was we took 1 year's worth of testing data, STIs and HIV, and we put it in a geographic information system, and we plotted it, and we looked for clusters. Then we saturated that zone with targeted prevention messages. And these messages, though, were not about your behavior. These messages were about how HIV lives in your community compared to the city overall. So the messages we put out wasn't you need to use a condom, because in fact, people in Harlem use condoms, and people in Harlem are not practicing riskier behaviors any more than people in the white parts of the city are. The reality is if you have more HIV in your community, there's a higher probability that that one unprotected encounter will result in the transmission of the virus. It's really about just the way that germs operate in the world. So our messages are, in New York City, it's 1 in 74 who are infected. In Harlem, it's 1 in 38. Then we did things like provide accessible on-the-spot testing. 20 hours a week, our mobile units were out there. You knew where they were. If you wanted a test, you came on in and got tested. And then we provide referrals to linkage to care. And not only medical care, but we have food and nutrition programs, we have housing programs and behavioral health. So you kind of could pick what it was you wanted, because we figured once we got you into the universe of service, we were going to keep you. So this is just a map showing you how we kind of put our data together, and you could see the kind of spread of testing that we have. The green dots on the left represent all of the people that we've actually tested, and then the red spots represent the clusters of HIV and STIs. So what did we find? 2008 is when we launched our initiative for the entire year, and you'll see the seropositivity rate for the Blocks program, which we also call zoned, resulted in a 2.7% positivity. Now, if you know our CDC project officers, and I'm not referring to Dr. McCree, but on the other end, like 2.7%, you gotta be kidding me. You can't get that up to 5? But the reality is, here we are testing people regardless of risk. The question we ask is not what you did. When was your last HIV test? And if you had an HIV test, 12 months and 1 day ago, we wanted to test you with us in that moment. The risk-based testing had a higher positivity rate, and you can see social networks, which is our social network program for MSM, did have a higher positivity rate at 9.5%. But that was 10 people. What we're trying to do is get more people in the community to understand the value and the role of testing. So in fact, that 90 positive people that we tested from zone-based is pretty darn good. Then in 2009, what you'll see happening here is the positivity rate, even for zone, went down. Positivity rate for risk went down. What happened in the zone-based project? As we are out in the community all the time with our Let's Do It t-shirts trying to talk people into testing, business owners wanted to know what we were doing. Churches, mosques wanted to have a piece of the action, and they said, well, come and test with us. We're not going to tell anybody no. But the reality is when you set up testing in some of these places, people who may know they're at risk because they belong to that mosque may not want to test in that moment. So you will find that you're not testing, you're not diagnosing anyone positive, but you are building capacity within the community to talk about the issue and to understand it as a community disease. So for us, that was a fantastic outcome. In terms of risk-based for social networks, and again, I'm not going to talk about that project here too tough, other than to say that we adapted the social network strategy so we could get more young men into the testing project. So I think all the strategies work. I wouldn't sell one over the other. I would say it really depends on what's happening in your district and what your district needs. Blocks 2, because of the interest of local businesses, we decided, well, let's make Blocks 2 all about the working poor, because a lot of the testing happens during the day when people are out at work. We do testing on the weekends, but a lot of the working poor work 6 or 7 days a week. We're not going to get them either. So this project was about setting up testing initiatives with pharmacies, botanicas, which in Harlem, there are places where a lot of our Latin American community residents go for things like care, spiritual guidance. But often if a person's feeling sick, they may go to the botanica if they don't have health insurance and look for some alternative remedy. So we set up mini clinics, kind of like what CVS had been doing around flu shots and vaccinations. We set up mini clinics in the pharmacies and the botanicas to deliver HIV, STI, and hepatitis C screenings. We also did things like reach out later on to gyms, to laundromats, any place where a person might go who doesn't have health insurance, is working all the time, and we've got to catch you on the fly. So our Blocks 2 data, we launched it in March 2010, so this is our data through October. It's about a 1% positivity rate, again, though very much in line with the city's diagnosis rate. Pharmacies, you can see 1.58% of the people who tested with us through the pharmacies have tested HIV positive. Because we have a clinic and because we also do ADAP enrollment, we're able to get those people linked to care in our clinic. We're also a federally qualified health center for the homeless, which means that if you don't have insurance, it's okay, we're going to take you anyway. The botanicas right now is at 0%, but that one has only been active for the last month. And what we find is once the store owners and other people who are using that business believe in your service, word of mouth, more people come out and test with you. And the other businesses, about less than about 0.5%, those the laundromats, and the car services are where we're targeting our immigrant Africans and Dominican populations. They work 7 days a week. So we take our vehicles out to the gas stations where they fill up and take a quick break, and we try to get them to test there. So a Blocks 2 project, you can see, is actually getting at the working poor. The vast majority of people who are testing with us are earning less than $20,000 a year. While that is very poor in New York City, these are actually working people earning, some teachers' aides earn about 18, and taxi drivers, depending on schedule, earn between $20,000 and $30,000 a year. So, and you can see 17% of those tested with us had never been tested before, and 40% were tested over a year ago. Integrating the STI screenings into what we do. Much of the STI screening we do is at our fixed site. Our mobile units are not equipped to do STI screening in the field. But you can see here the rates of chlamydia diagnosis. Gonorrhea, not so much, but chlamydia particularly high among both men and women in our community. But the syphilis project is almost exclusively young men under the age of 29 who have sex with other men, and that is at almost 9% positivity. And often what we find is when we test someone positive for syphilis, if we can test them for HIV, we do have a higher dual diagnosis rate in the under 29 YMSM population. So building community capacity, in 2008, we started work with New Hope for the World Ministries, which is a network of small churches in Harlem who said, listen, we do this annual event every year, come and test with us. We went out and tested, and they said, you know what, that's nice, but that's not really good enough. We want to be able to do outreach and test with you. So we started a process this year in 2010 where we helped them acquire a CLIA waiver so that they could actually become test counselors and set up their own labs to do HIV testing as part of their ministry. And then we did a series of trainings with them to become HIV test counselors so that they can do it as part of their pastoral ministries. So you can see over the summertime, the trainings were very much targeted to them to understand the connecting their faith with the HIV testing project so that their counseling was appropriate for the various target populations they would encounter. CLIA is the Clinical Laboratories Something Act Improvement. Thank you very much. And you have to get a waiver because the HIV test is considered like a lab in and of itself, and you have to be trained, you have to have protocols, and you must follow the protocols strictly. And so that does take some education and training to do and to maintain your protocols. You also have to have a lab director. So if you are a church-based program, you may not be able to afford a laboratory director, so our chief medical officer does that for free. And so this was our Reach Week event that we did. These are our volunteers and staff. On the top left picture, the gentleman in blue is Pastor Kennedy, who is kind of leading the church response with us. The middle is our borough president. And you can see the Let's Do It t-shirts that we've used over the years for the Blocks Initiative. And we keep the logo the same because we also give them out at the testing events so that it becomes part of the Harlem scenery. Collaborating with government. In 2009, City Council Speaker Quinn wanted to do a project called I Talk About HIV. And so we thought, wow, that sounds really cool. So we just got a staff person who knows how to work a video camera to go around and talk to different staff and clients within the organization. We posted them up on our website, and we sent them to Council Speaker Quinn, who then put them up on the City Council's website. I'm going to show you those, one of those videos. But before I do that, I also just wanted to give you a sense of some of the materials that we use. Incentives are great, and I'll pass these around. So the pharmacies we work with in Blocks 2 has the pharmacies logo, and on the other side has our Blocks promotion. I'll pass that around that way. That's one of the pharmacies. This is the other pharmacy. For the restaurants that we're working with, and the delis, we have business cards. So the business card on one side is their business card. The back is our Blocks project. So at every opportunity, people get a sense of who we are and what we're doing. And then finally, we have our Blocks project pill boxes, so that every time somebody picks up a prescription, in addition to having the advertising on the pharmacy bag, you also get our pill box. And this video is our director, our senior director of government policy, but he is also a man living with HIV, and this is his story.
Hi, my name is Kali Lindsay. I'm the senior director for federal policy with Harlem United. And I talk about HIV/AIDS because every day I fall asleep thinking about living with AIDS, and every morning I wake up thinking about living with AIDS. I talk about HIV/AIDS because more black gay men find out that they have HIV each year than earn bachelor's degrees. I talk about HIV/AIDS because silence equals death. And not talking about HIV and sexuality is how I became infected, and allows every 9.5 minutes for another person to become infected with HIV in the United States, where 1 in 16 black men and 1 in 30 black women will contract HIV in their lifetime. I talk about HIV/AIDS because awareness days have been reduced to symbolism instead of acting as benchmarks to track our progress in our fight against the domestic epidemic. I talk about HIV/AIDS because even though I'm sitting here sharing my story with you, you may one day become infected with HIV, though I wouldn't wish that on anyone.
So I just had some acknowledgments at the end. I just wanted to thank our New York City Department of Health, State Department of Health, and of course Centers for Disease Control for all of the support they've given us over the year. Thank you.